This is Tom Lee, editor-in-chief of NEJM Catalyst, and we're talking today about the challenge of making a primary care a job that's not only doable, but attractive. We're discussing this with Chris Andreoli, who is the CEO of Atrius Health and Reliant Medical Group, both parts of Optum Health. Chris himself is an ophthalmologist, a vitreoretinal surgeon who grew up professionally at Atrius, the Boston area multi-specialty group that has been a longtime leader in managed care and has been the leader of Reliant and other Optum groups in New England. I know there are lots of grim stories about primary care these days, but I recently learned that there's some positive stories as well at Atrius and other parts of the system that are under Chris's leadership. And I asked him whether he'd come on the air with us and share some of what seems to actually be helping in his organization. So, Chris, let's start with checking to see whether my take is correct. My take is that you have something of a turnaround story to describe in primary care. Is that right?
First of all, thanks, Tom. Appreciate the opportunity to be here. It's not often that you find a podcast that wants to talk primary care and value-based care, so we're super excited for the opportunity, and thank you very much for inviting us. And yes, I think you have it right. We at Atrius and Reliance certainly haven't figured out all the mysteries of managing primary care and healthcare, but in the years leading up to the pandemic and then certainly worsened during COVID, we were grappling with all the same issues as all the systems were and continue to be. Shrinking primary care workforces, consolidation of giant systems around us, as rising competition, national competitors entering the market. COVID made a lot of that worse with accelerated retirements. And we were just struggling to make the necessary capital investments. And we're seeing clinician burnout, particularly primary care and burnout, to be at all-time highs. And we're finding ourselves in a little better spot now with the support of Optum, the three medical groups that I oversee, as you pointed out. Now all partner with Optum, have been able to make capital investments in our physical plants, in our people, in our systems, and are generally thriving in a way that we hadn't been before. We're now growing again, more clinicians, more primary care clinicians, more patients that we're serving, more locations, and generally more offerings. We see that through our practice. We've been able to modernize many of our facilities, entering new areas, opening new buildings, but also renovating practices that have been around for decades that have been overdue in their physical place, expanding to new service areas, new geographies within Massachusetts and Connecticut, but also filling in our multi-specialty model in areas where it was lacking throughout our geography, adding things like infusion centers or imaging that we didn't have in certain regions. And ultimately, we're seeing the result with lower primary care provider turnover at rates that's the lowest it's been in the decades that I've been involved in leadership.
Well, one great thing that you and your colleagues did for primary care doctors is work to reduce the inbox crisis. Now, I have to admit that one reason I think it was great was because you wrote about it in our journal, NEJM Catalyst. Was actually one of the most frequently viewed articles that we published in the last few years. Now, for folks who haven't read that article, can you give a quick description of what you guys did to reduce the inbox burden and an update on how that work is going?
Sure, Tom. We're equally biased that it's some great work, regardless of who's talking about it, whether it's Catalyst or anybody else. Um, More or less, the inbox crisis is sort of at the center of what we've been working on for years at Atrius and Reliant. There's a bit of a perfect storm that has led to this problem. Our patients and our communities and our populations are all living longer, and as medicine has gotten better and invented new treatments and drugs and preventative therapies, and as we age, we're also dealing with more chronic diseases, more treatments, more test results coming in, more consultants weighing in on all of our patients, and that's all funneling in through an electronic medical record that also has a portal that allows communication between our healthcare providers and our patients. We use Epic. We've been one of the longest standing Epic shops, and our patient portal is the most adopted by our patients of any of the groups that are in the Epic network. Over 90% of our patients are actively engaged with us through the patient portal. So there's more volume coming in on more patients, on more different things and more different results. And I'd say the consumerism era has added to that, and COVID just made it exponentially more as patients were sort of locked down and at home and got more facile and used to communicating asynchronously with their providers. So the amount of information coming in has just exponentially worsened the burnout crisis in all physicians, but I'd say in particular primary care providers as the gatekeeper of all this information, and also the folks that are bearing the burden of keeping all this information straight, keeping their patient healthy. So, that problem is, if you had to pick the problem, is the problem with provider burnout and with managing our workforce. So as you point out, and as the article referred to, we've spent a lot of time, energy, and money on this problem over the years, and continue to, and will continue to. And some of the work that you're talking about, or that you reported on previously, is we've done a bunch of things. We started out by systematically analyzing what's in the inbox, where are the highest volume of flow of information coming in, and what was most actionable for us to be able to debulk, deburden, or not just decrease from the provider lens, but also in our effort to take better care of patients and be more responsive to them, where could we act to make the biggest impact? And so we plotted out several years worth of work and continue to work through it. Some of the examples of this work are labs. We were seeing more and more lab results coming in as different recommendations recommend more and more lab work for different diseases. Those results flow right in, and they flow in from our system and other systems. So we've found a way, and all this work is true across all these in baskets, but we've informed all of this work by thought leaders from our providers and our clinical leaders. So we gathered the data, we gathered the doctors to inform what is the best decisions to make. And in the world of labs, we've been able to weed out some of the normal labs where we auto process and auto send letters to our patients for some of the results that don't need to be seen directly or acted on by our providers. Not every lab falls in that category, but our clinicians weighed in on those that were felt to be clinically appropriate or in the best interest to just get in the patient's hands as soon as we can, and not cloud all of the other important abnormal findings that our clinicians should spend their attention on. So we've had great success in this normal lab work, and the more and more we add to being able to triage out, the more and more flow in. So it's an ongoing body of work that we continue to do. Similarly, refills and everything about medication renewal and prescribing was another large area of volume coming in the inbox, and an area that was ripe for quality improvement, getting things done quickly for our patients so that they weren't not taking their needed medicines because of speed of turnaround, but also getting it right. Every time you're interacting with something like this, there's an opportunity to make an error. And so improving our turnaround time and our accuracy of prescription response was as important as debulking the work. And so we've automated and delegated to teams, and again, all informed by clinician committees deciding what are the best protocols and what are the things that we can safely take out of the hands of a provider directly and into a delegated team. And as we've built some of these protocols and these centralized workforces, we've then been able to leverage those to do even more work on behalf of our patients. So if someone's calling in to get their antihypertensive medicine refilled, we take that interaction or that opportunity with that delegated team to fill care gaps, make sure that they've been in for their blood pressure check, which is the medicine that they're calling about, but also look and make sure they've had their mammogram or colonoscopy or other preventative work. Since they're engaged with us at that moment, we don't want to miss the opportunity to do all the other things through an appropriate team member that we think is in their best interests. So a lot of gains continue to happen across prescription renewals. Right now, we're in the middle of spreading those learnings to some of the other groups. We did some of that pioneering work at Atrius. We're spreading similar processes and protocols and shared learnings to our colleagues at Reliant Medical Group and also to ProHealth physicians in Connecticut so that more and more of our patients can benefit from some of that work. Overlapping, similar, different is all things prior authorization. These days, there's an expanding volume of prior authorization work, both with prescriptions, but also imaging and surgeries and other things. And that is an area that has led to increased provider burnout as well, and led to potential for delay or errors on the patient side. So similar to the RX renewal, there's multiple prongs of benefit by doing this work beyond just physician burnout. We've centralized much of that work. We've delegated teams. An example of that is all of our imaging prior authorizations are now handled by our ancillary services imaging team rather than in the primary care department. And we found that the primary goal is met of taking some of that work away from our primary care physicians, but also we do it more accurately, we do it faster, we do it with less effort. There's less peer-to-peer reviews that are needed. So overall, it's just taking less strain and less work by the whole system, but in particular, less work in primary care.
Well, I know there's a tremendous amount of work over many years by many people that went into this. And I hope and expect that one of the results is that physicians who are working in that system would be reluctant to go to a place where that kind of support wasn't there. So I'm sure this is part of the turnaround story. But I also know there are other things that you're doing and focusing on the people rather than just the IT. How are you organizing other caregivers around your primary care doctors?
I mean, to your first part of your point, I do think that we want to pride ourselves in being the place where we make it just easier to deliver the great care that we know all doctors and clinicians want to give. So we hope that we're offering the best place for folks to work and hope that is proof in the data of our turnover rates and the people who want to come to work here. And you're exactly right. We view primary care and generally clinician job doability um, as a as a team sport or a team effort, and that team is also inclusive of our electronic medical record. They're a essential part of our team that they've been there since the 90s. But there's many other team members and humans that are part of that as well. There's just too much work, too many patients for just a single primary care doctor in an office to be able to manage a population of patients. There aren't enough of them in America. There are not enough of them in Massachusetts, and the demands and the burden and the data are just too great. So our biggest commitment is to the team, and that is an expansive word. It starts with a primary care physician being the center of a panel of patients or population that they're caring for. But with each primary care physician, our standard or base model is another member, another clinician, an advanced practice clinician teaming with the primary care provider. That primary care provider could either be an MD or an APC, and then on top of that, at least a one-to-one ratio so that there's two clinicians that develop a longitudinal relationship with that panel of patients. And in many cases, that team is even larger. In some cases, we have two or three teaming APCs with our primary care clinician. And that clinician group is sort of the center, but is surrounded by circles of team members at varying distances from that clinical group. And that starts in the local office with medical assistants and nursing and LPNs and medical secretaries in the office, making the hyper local team experience directly dedicated to that group of patients. There's sort of wider circles of team members that we put at a site level, things like population health managers or clinical pharmacists, and then other supports that are further and further away, either remotely working from home or working centrally, things like case management or clinical pharmacists or other such supports that help from afar and can sort of dive in as necessary or as pulled for. Even our entire specialty complement is sort of built around that concept of managing as a team. So whether it's palliative care or geriatric support or ophthalmologists like me, we all sort of view ourselves as that extended team managing a population of patients and are all connected either directly, locally, or virtually. And we try and get everyone on the team from local medical assistant to sub specialist or remote population health worker working at the top of their license, including the clinicians, so that we're leveraging the expertise of everyone we put on that team. And then we layer the technologies on top of them so that from the individual people, we're getting as much out of them and we're able to expand their expertise using technologies as a force multiplier and also trying to spend as much time and energy getting the technology out of their way, reducing clicks and making it easy for them to do their work.
So, what are you measuring to assess how you're doing?
So, I think the bottom line is these days we're growing and thriving, and I measure that easiest or simplest by the fact that we're growing. So there's more people choosing to work here than there are leaving or retiring. There's more patients choosing to get their care here. So I think that's a very important statistic that we look at, showing that when you add it all together, we're doing something right. But we put a lot of different resources into breaking that down to understand how we're doing what we're doing. A lot of the work on clinician burnout and provider burnout is led by an office where we have a clinical affairs department led by our associate CMO, Ann Dixon, and her team implements a lot of the work and helps us triage and prioritize a lot of our work on provider experience, provider wellness. She's been recognized by Optum as an expert in this field, and actually just recently now has taken on a role nationally across Optum, spreading some of these learnings elsewhere. But she focuses on things like personal resilience, practice efficiency, returning the joy to medicine, developing a culture of well-being, and helping us measure what we're doing. She helps us prioritize investments in our folks and then understanding whether it's working well or not. And we survey people locally, longitudinally over time. We do experience surveys as part of Optum and compare ourselves nationally. Um, and then we're doing well and we're doing better. We've invested a lot of time and energy and money and things like our provider turnover has gone down, but things like our burnout indexes have steadily improved year after year after year as we've measured and as we've made these investments. And we've earned some awards. From Joy of Medicine recognitions in 21 and 23, and other such things. So I think we're objectively measuring it and we're being recognized from the outside. But then much more subjectively, we try and create many different forums by which we can hear from the practice to understand if we're doing things right. Me and other members of my senior leadership team do regular site visits to all the practices. And I personally find I started doing this as I stepped into some of the roles during COVID, and I've continued it since in the various roles that I've entered more recently. I find that gives me the best sort of real time vibe of the practice, hearing directly from all my colleagues that I've known for the 17, 18 years that I've worked here, how things are going. And after a few weeks of a few site visits, you quickly learn what the strains are on the practice, or what the vibe is, or what the energy level is, or what the overwhelming burden of work coming in with flu season might be, or how we're doing with MA turnover that month or that year, and the things that are stressing out the docs. We luckily have a very engaged clinician workforce, and they're happily willing to share their feedback with me when we're out there, or through email or through texts. So I put that more in the category of subjective measurement, but we're committed to hearing from the practice. My CMO does regular CMO office hours. My COO does the same, and it's pretty much a virtual open mic. We set up a Teams or a Zoom, and any of our clinicians can join and just ask questions and share their concerns. We have a clinician experience council, similar, where it meets on regular cadence that we can hear from people. So, part of measuring is, I'd say, just showing up and listening to what people have to say.
Well, other than the inbox work, what kind of IT related innovations have you introduced?
So it's an interesting time. We've been heavily invested in technology since well before the words AI came along, but now AI is at the scene. And so we're trying to understand what are the best technologies out there that are going to actually make things better. I'd say technology has been the promise that will solve all the problems of healthcare. And up till now in my career, I'm not sure that it has. We've just seen increasing burden of work and information coming in, but we may be at an inflection point. Maybe AI may be the thing that helps us. We've very recently rolled out an AI powered scribe technology. Our practice has provided scribe supports or documentation supports through things like Dragon for a while now, but the latest generation of AI-powered scribe technology is really quite impressive. You can just have a conversation with your patient through the exam and through the plan, looking at the patient the entire time, not typing and looking at your electronic medical record. And the AI-powered scribe technology will summarize that all into a comprehensive note that you review afterwards. And through our rollout, we're universally getting great praise that this generation of the technology is um, giant steps better than prior generations, both in our ability to scale it due to cost and ease of use, but also in the output and the product that is being provided. It's saving time. It's making the notes more accurate. It's putting more face-to-face time between the patient and clinician, and afterwards less time reviewing, less time documenting at home when you could otherwise be with your family. So that's been a recent and great win. Some seemingly simple but amazingly elegant and time-saving technologies that we've rolled out recently. Tap and go or tap in, tap out. It's a single sign-on. You just tap your badge onto your computer and it logs you into the computer itself and into the electronic medical record. And then out, and each time a different team member, whether it's a medical assistant or medical secretary or the clinician, goes in and out of the same room. You can just tap in and tap out without having to type your name and password. If you're someone like me who has a super long name, Christopher Andrioli, your username is very long, and in the era of being cyber secure, passwords are 14 characters or longer. And so you can imagine going in and out with anywhere from 20 to 50 patient visits and having to type all that in. We did some quick estimates and found that when we rolled out this technology, just at Atrius Health alone, we're saving something like 1 billion key clicks per year just from a single sign-on, tap in, tap out technology. We've spent lots of different efforts and times at clinical decision supports, prescribing support tools that tee up information to help set up things with one-click order sets or automated information at your fingertips when you're trying to do something that you do multiple times a day. Each of these saves millions of clicks a year as you're trying to refill a prescription or the right set of things or put the right information in a patient's chart for them. We we're also trying to leverage digital health. We went heavy as everyone did during COVID with video visit technology, but there's a whole host of digital technologies that have emerged throughout COVID and after, and some are sticking and advancing more than others. We have first-in-class approaches in behavioral health, which has become a crisis for us all to deal with. The number of behavioral health needs in our pediatric and adult populations just continues to explode. So we use telehealth and have found that to be a very effective synchronous video visit use case, but also other digital interventions in our behavioral health population is an innovation that we began at Reliant Medical Group and have expanded to Atrius Health as well. We've rolled out symptom checkers first at Reliant, spreading it to Atrius, tied it to back-end asynchronous e-visits where a patient can solve some of their problems themselves online, and in other cases, enter some of their information and get a response quickly through their online portal. And that allows the patient to get the care they need when they're available and us to respond quickly without it being in a traditional face-to-face visit. So there's a lot in this world of sort of digital health related interventions that continue to unfold and will as we go forward.
Well, wrapping up, as you look further down the road, it really does seem likely that the supply demand mismatch in primary care is only going to get worse. Your thoughts on how we're going to have to address that?
Yeah, I think you're right. I think we're already there, Tom. I don't think there are enough primary care providers in the country. Massachusetts is probably less in dire states than the rest of the country. And even here, there's not enough PCPs for the patients to provide the level of coverage and care that we believe needs to happen. And that's just going to continue to get worse as we age, as our disease burden increases, and as less and less folks go from medical school into primary care and more continue to choose various specialties. So I think the problem is real and is now and is going to just continue to be a worse mismatch over time. I think we believe strongly that the primary care provider, the PCP, will always remain the quarterback of the team. But as we talked about a bit earlier, I think we need to continue to develop and expand the team around them, including population health and behavioral health and specialties and clinical pharmacy and embedded ancillaries and home-based modalities, just to expand that support system around the primary care provider, building a system that can create synergies among these areas to help meet our patient demands. Advanced practice clinicians, APCs. Again, the moment to invest and deploy APCs is now. We have essentially as many APCs as we do MDs in our system, and that will just continue to grow. It's been our fastest growing area of clinicians and will continue to be. And with that comes the need to train them on whatever your system is working on. And in my world, it's ambulatory primary care. So we've created a variety of different ways to train people in our model of value-based care. We've created a residency-like program for new grad APCs who may not have had exposure to ambulatory medicine, to primary care, or certainly to a value-based care approach to primary care. So investing in training those future generations of team members, whether they're APCs or medical assistants or nurses to what we're trying to do, will become increasingly important, an important place to spend our time, energy, and money.
Well, Chris, you covered a dazzling array of types of initiatives, and I know they're all real from being here in town and talking to colleagues and friends who are working with you. And as impressive as it is, I know it won't be enough, and I'm fully expecting that you and your colleagues are going to be on the forefront on figuring out other innovations that it will take to make primary care a doable, and I do think a great job. As someone who practices primary care, I don't think there's a better thing to do in medicine than deliver primary care to patients. And I am pleased and not surprised that you and your colleagues are making that possible for your patients. So we will be checking back with you to get a good feel for what the cutting edge is for primary care for years to come. Thanks once again.
Thank you so much, Tom. I appreciate your support. We can't do this alone, so it takes advocates like you and your program to support the work we're doing. And we've had help along the way, whether it's from our payer partners who have supported our approaches to value-based care, or our hospital partners, or regulatory environment in the state. So it really we've been uniquely benefited from starting this work in Massachusetts and are excited to have the opportunity to spread some of this work across the country through our collaboration with Optum. But thank you again to invite us here to talk about it.